if we increase the number of cycles to meet demand of the 1 in 6 people who suffer from infertility, we need the physician care to meet this demand because, of course, there's the laboratory element, but there is the sort of clinical care. And the current capacity in REI care does not meet that. And so we need a collaborative model where OBGYNs, supported and supervised by REIs, are part of the sort of fertility care model, the future fertility care model.
What should OBGYNs be doing in fertility care? They're coming into IVF, but they're not REIs. This debate rages on in this field, and I want to keep exploring different angles and hearing different voices. My guest, Dr. Stephanie Kuku, was a practicing OBGYN surgeon in the NHS in the UK. She's been an advisor to some 75 health tech startups. Now she's the chief knowledge officer of Conceivable. She's not trying to do IVF, so from my point of view, she doesn't seem to have a dog in this fight. So I ask, what do OBGYNs need from REIs? What do REIs need of OBGYNs? What's the oversight that REIs have over OBGYNs in other countries? What are OBGYNs qualified to do with regard to fertility care and not qualified to do without REI training? And I make Stephanie describe what an REI's work might look like when he or she is overseeing far more cases and potentially teams of providers and APPs underneath him or her. Dr. Kuku thinks we'll need more REIs, not less. The career opportunities will be more, not less. The livelihood they make will be greater if they embrace the necessary changes and are part of leading the way. Dr. Kuku is talking about the research that OBGYNs and REIs can collaborate on, including the 100-person IRB study that Conceivable Life Sciences is running right now. How will technologies like Conceivable bring OBGYNs and REIs closer together? Listen in on my conversation with Dr. Stephanie Kuku.
Today's advertiser helped make the production and delivery of this episode possible for free to you. But the themes expressed by the guests do not necessarily reflect the views of Inside Reproductive Health, nor of the advertiser. The advertiser does not have editorial control over the content of this episode, and the guest's appearance is not an endorsement of the advertiser.
Dr. Kuku, Stephanie, welcome to the home edition of the Inside Reproductive Health podcast.
Thank you, Griffin. I'm so excited to be here.
As you can see, it's like being in my living room, except if I had a camera crew with me. And this must be how naturally beautiful people or seemingly naturally beautiful people feel all the time. All the work that goes into the most natural setting. Setting up a couch and being very self-conscious about how I turn my jacket. I want to talk to you about the relationship between REIs and OBGYNs. In your view, what do OBGYNs need from REIs in order to be more involved in fertility care?
Griffin, so firstly, I'd love to remind people, and I'm sure a lot of people know this, that REIs are OBGYNs who have subspecialized in reproductive endocrinology and infertility, hence REI. OBGYNs are obstetrics and gynecology doctors. We all go through an OBGYN residency program, and then we subspecialize. So I, for example, chose to do a subspecialization in oncology. Therefore, I'm not a fertility specialist, but a gynecological cancer specialist. The REI fellowships traditionally in the US and abroad have been few and far between. So if you look at the numbers of REIs compared to OBGYNs, there are under 1,500 REIs in the US, and there are over 40,000 OBGYNs. The problem, and the reason we're having this conversation, is that there is a supply and demand mismatch in IVF care, in infertility treatment. 1 in 6 people suffer from infertility, yet we are not meeting the needs of over 90%. And so therefore we are at an inflection point when we need to be able to increase supply, increase access to fertility care. And obviously one of the most important things there is increasing lab operations. And that's what we're doing. We're automating the IVF lab so that we can increase the number of cycles that we do per year. Now, if we increase the number of cycles to meet demand of the 1 in 6 people who suffer from infertility. We need the physician care to meet this demand because, of course, there's the laboratory element, but there is the sort of clinical care. And the current capacity in REI care does not meet that. And so we need a collaborative model where OBGYNs, supported and supervised by REIs, are part of the sort of fertility care model, the future fertility care model. And I think what OBGYNs need is this support and this a collaborative hybrid model where they sort of can be part of fertility care. They see the low-risk patients. Obviously, complex cases go straight to the REIs, and they have, training support, virtual hybrid support with REIs to really be the first point of care for fertility care and fertility patients.
I think many REIs have a hard time visualizing that because this debate's been going on for a while. I have it in person with people whenever I can stoke the fire a little bit and get people debating. And you have REIs that say, listen, this is not that complicated. We could teach a monkey to do egg retrievals. And then you have the other camp that says it's not just about egg retrievals. There's a lot more that goes into REI. And it seems to me that even the folks in that camp see your point about the need that there's just not enough REIs, and they'll say things like, we need to add more fellowships. It's like, well, yeah, but how many more fellowships are we going to add? And it's a drop in the bucket compared to what needs to happen. But I think that camp has a hard time seeing what that support system looks like. It seems to me like their worry is that OBGYNs are just going to start taking over IVF without any oversight. You talked about a support system and some oversight. What does that look like?
So I think it's important to remember that OBGYNs are trained in obstetrics and gynecology. REIs have gone through OBGYN residency. To put things in context, and I think David Sable and Eduardo Harrington published this last year in a paper titled Meeting the Demand for Fertility Services in the US, OBGYNs have to perform very technical surgical procedures. So to get signed off as a board-certified OBGYN, you need to have done almost 100 hysterectomies. And so the argument that it's, OBGYNs aren't qualified, you have to have training in ultrasound, you have to do hysterectomies, which are far more complex and technical than egg retrievals, doesn't really stand. I think we need to go back and think about why REIs are cautious. I would hope that the first reason is patient care. We must do everything to maintain and improve patient outcomes in IVF. And that means making sure that we are very clear about how the model will work. As I said before, it's very simple. OBGYNs do low-risk cases. I think a lot of people are happy with OBGYNs doing the clinical part of care. So they do the assessments, they do the triage, they do the holistic work, they do the follicular monitoring and medication management. I think to say that an OBGYN can't manage follicular stimulation, ovarian stimulation, isn't correct. But the important thing there is everything will be done under REI supervision. What people need to understand is we need to increase supply. We need to make IVF more accessible. And to do that, we need technology. And we're going to do that with automating the IVF lab, which means there'll be more cycles and there'll be more work. Now, REIs alone cannot meet this demand. Clinical efficiency is the goal. And with OBGYNs starting this process, being involved in the very low-risk elements of this, under REI supervision, with strict protocols. I always say OBGYNs, we love following protocols. It's the most litigious specialty. We are very good at sort of triaging high risk, low risk. Any OBGYN would know this is out of my remit. It's time to get the REI, telemedicine, this sort of hybrid tech-enabled model is the future. It will happen. It's not an if. It will happen. We need OBGYNs who are already the first point of contact for the patients. Patient first. Patients trust their OBGYNs. There's continuity of care where you go to your REI, you come back. The REIs, the OBGYN is involved in this care model, and that's the future.
I want to come back to what that supervision and that caseload distribution looks like, but I want to talk about the complications that REIs sometimes feel. And I had this debate going on in a different dinner, and one very, very high volume REI said, I've been doing this for years, I've never had a complication with internal bleeding. But another one said, I've had maybe 3 over the course of my career. So they're rare, but they can happen, and it would be a really big concern. I'm going to try paraphrasing something you said yesterday, so you're going to correct me if I got this wrong. But and you don't really have a dog in this fight, because you're not a practicing OBGYN right now. You're not trying to do IVF, but you were an OBGYN surgeon. To me, it sounded like if you had a complication, that maybe the REI isn't the first person that you would want to be on the scene there. You might want an OBGYN surgeon. I'm paraphrasing, so clean up what I'm saying.
Of course. Well, it depends on the REI. But I think, generally in surgical practice, they say don't do a procedure for which you can't deal with the complications. And so if you think about the fact that REIs are specialized in egg retrievals, and that they definitely do less emergency laparoscopies and laparotomies than OBGYNs, ambulatory gynecologists. By the way, I trained as a cancer surgeon, so I can guarantee you that even though I haven't practiced for 5 years, I could probably deal with an acutely bleeding patient even now better than a lot of my REI friends who haven't done emergency laparoscopies for years. In fact, I was speaking to an REI friend in New York, and they said if I ever did have a complication, I wouldn't try and deal with it. I'll put them in an ambulance to the nearest gynae unit, because I think that would be best for the patient. And so I think this idea that OBGYNs will not be able to deal with a complication of an egg retrieval, say you nick a pelvic artery and the patient is bleeding, doesn't really hold, because OBGYNs are gynecologists. We do more gynecological surgery on a day-to-day basis than REIs.
Do OBGYNs do retrievals in the UK?
In Europe and UK, some OBGYNs who have a specialist interest in fertility care and who've had some additional training, absolutely yes.
What does that training typically look like? Because a fellowship in this case tends to be more of an American context, right? You've got a 3-year REI fellowship training in the US, 2-year fellowship REI training in Canada, but does that exist in the UK in that form, or
we
Europe?
Absolutely do. We have subspecialty training programs for fertility, for oncology, but within Europe and the UK, you have what we call clinical fellows. So you don't go through a 3-year training program, but you have a sort of truncated training program where you are a gynecologist with a special interest. You are under supervision of an REI. You go through sort of years of practice and training and practice. You do lots of cases supervised by an REI. And yes, there are a lot of gynecologists in Europe and UK who are already involved in egg retrievals. I don't advocate that gynecologists should do embryo transfers. I think that the most important part, if you think about REI...
Why not? What's the difference between transfer and retrieval in that sense?
I think that the transfer denotes the embryo transfer comes in sort of under the fertility care embryology laboratory services. I think that we must separate what is clinical gynecology and what is sort of embryology, laboratory, and IVF. And I really believe that the best person for a job should do the job. So if we are thinking about embryo transfers, we should leave that to the REIs, because at that point you're trying to return the embryo. I think as a patient, I would be very comfortable with my gynecologist dealing with my initial fertility care, managing my stimulation. My gynecologist is brilliant at scanning. She's a PhD in ultrasound. But I would want my REI doing everything from the point at which my eggs are retrieved and the embryo is transferred, just that separation. And then, of course, I'd want to go back to my OBGYN. I think that we must have, and I don't know who's going to set it, just very clear protocols, so nobody's stepping on anyone's toes, and accountability can be very clear. And I don't want to go into how that model is going to look like because there are lots of debates, but I think that a collaborative model also has to have very clear delineations, and we want to make it very clear what gynecologists should be involved in and where their role is, which is the patient care, the assessment, anything that can be done. If you think of patients that live an hour from the fertility center, anything that can be done without you having to travel an hour to the fertility center, for example, ultrasounds, follicular monitoring, and then all you have to do is go to your fertility center for egg retrievals and embryo transfer. I think that's how the model in reality is going to work in the future.
I think that travel is such a big piece that we don't talk about. So I took the number of IVF labs in the US, and from the CDC report, from the latest data, which is 2022, there's 450 something, like 470 something like that. And I told ChatGPT to look up what number of U.S. counties or county equivalents each of them are in, and then I told ChatGPT to look up how many counties there are in the United States. Guess what percentage? To take a wild guess, what percentage of U.S. counties have an IVF lab?
Probably less than 10.
It's 8%.
Yeah.
It's pretty good. 8% of U.S. counties or county equivalents have an IVF lab. So that means that there are people in large parts of this country that are traveling hours to get IVF. And as far as there might not even be an IVF lab in Alaska. Previously, there had been people doing remote monitoring, and then you've got to fly to Seattle to get IVF treatment. So there's this big access problem. There's far more OBGYNs to the tune of 40,000. In the UK and Europe, for those OBGYNs that are doing retrievals under the supervision of an REI, is the REI in the room physically, or is there a number of OBGYNs doing retrievals, and an REI is their case manager that's always on site? How does that work?
I think it's safe to say that majority of retrievals, and I know we're back to retrievals, are done by REIs. There is a percentage, which I'd say is under 50%, that are done by gynecologists with a special interest in fertility who have had additional training, especially in places like Spain. And in that, there's always an REI in the unit, absolutely, who is accountable. But of course, I think that, again, we keep coming back to the sort of the retrievals. I don't think that the retrievals are where we should be focusing on. I think it's the point of care for patients. We talked about these fertility deserts, underserved areas. How do we get this sort of streamline to get patients through faster pathways, increase clinical efficiency, the waiting times from being referred from your gynecologist and REI, without having these OBGYN-led fertility hubs where essentially OBGYNs are starting the process, the triage, the assessment. They're making sure that they know which patients are high risk and low risk. They send the high risk ones straight off to the REIs. There's less waiting times. So imagine a world where we have automated the IVF lab and we are seeing, thousands of cycles, more so than the current REIs in the US and globally can manage. And so we need the OBGYNs as the first point of call to almost start the first part, the clinical care, the ovarian stimulation, and then patients travel, adjust for the sort of lab operations, as it were, to centralized IVF centers powered by technology, so that we can meet this demand with more cycles.
So REIs are seeing complicated cases. They're doing the transfers. Who's setting the protocols? In Spain, are the OBGYNs tending to set protocols? Are they choosing from a menu?
Absolutely not. Infertility care will always be led by REIs. I think that much is clear. REIs set protocols. They're the specialists. But non-REI professionals who have adequate training follow safe protocols to be involved in part of this fertility care. And I think we have to be very, doctors, especially OBGYNs, are very good at following protocols. So we must make sure that we don't get into the, I think the debate over fertility care and REIs is sort of losing focus. We need to bring it back to patient care, care delivery, collaborative models, setting clear boundaries, and making sure we can meet the demand and meet the need of patients. I think that patients want their OBGYNs involved because they're the first point of care, but I think they also want their REIs to be leading this care. And so nobody's saying that REIs are going to take over, and I think that that's where we're not making progress, because it's always about what REI should do. It's the debate has turned into this sort of turf war, but it shouldn't be. It's a collaborative model to increase clinical efficiency. OBGYNs are OBGYNs and REIs are specialists. So how can they do what they're already doing, which is assessing fertility patients, deciding who needs to go straight to fertility care, deciding who can, be tested on simple ovulation induction protocols, hybrid models of care whereby, you have a REI colleague who says, if you can manage the stimulation, and then you can send the patient to us for, egg retrieval and transfer. That's what's happening in Europe. So I think, again, we need to be clear that GYNs, OBGYNs will have their role, but REIs will always lead fertility care.
Talk about the research you've been working on the last year or so.
So what we're doing in Conceivable, and obviously, we started this conversation talking about OBGYNs and REIs and this sort of the future collaborative model of care. But I think it's important to remember that in order to meet this demand, lots of things have to happen. So first and foremost, everything happens in the lab. The miracle happens in the lab. And that's why at Conceivable, we are automating the IVF lab so we can increase the demand. The goal to increasing access, of course, is reducing cost, improving outcomes, and making sure that we can meet the demand for everyone in the US and globally. And so what we are doing is trying to show that we have the real world evidence to prove that automating the IVF lab is safe and effective. And even our hypothesis is that we can improve outcomes from the current standard. We have started with preclinical testing and have gone through very rigorous evidence generation steps, and a lot of our work will soon start to be published. We started with mouse, animal gametes, donor samples. We went into an IRB proof of concept study where we have 12 live births, 41 patients from our experimental arm, which show that our prototypes, which have automated sperm, egg, and ICSI, sperm preparation, egg preparation, and ICSI, using one of those prototypes or in combination, can get the outcomes that we're desiring. And we've had a 51% pregnancy rate, which is comparable to the best clinics in the world. We've now started this 100-patient validation study, IRB, to take patients through our lineup of automation. So Aura is a full, complete automated lab workstation, and our goal is to show the world that it's safe. It's and it can improve outcomes, and that's the sort of the study we're doing now.
How far are we into that study? Of those 100 patients, have some of them cycled, or all of them cycled, or somewhere along the road?
So we just started. We have 33 of the 100 patients already recruited, and we just started treating our first patients. So we have 6 months to go, but we're hoping that we have some really exciting data to show by the end of this year.
By the end of 2025, you're
absolutely, that's the goal.
That's the goal. Some data to share. What else do you hope to research in the future? If you had your druthers, what would you, if funding wasn't an object, what would you like to see more data on?
I think that there is so much potential. I think one of the most important things to accept is that, especially when you implement new technology, you never stop reaching to continue to improve outcomes. So one of the beauties of our technology, we have a cloud system that records over 100 data points, that we are going to have world-class data that no one has on all the confounders. And so that we can take this data and look and continuously trying to improve on the outcomes of IVF. And I think that is key.
How do you see collaborating with other OBGYNs or REIs who might want that data or involving them in future studies?
I mean, we are speaking to so many partners at the moment, from big IVF groups to OBGYN small practices who are super excited about partnering with us, but also excited about the possibility of improving outcomes for their patients. One, with automation; two, with the data that we can use to harness to continue to improve outcomes; but three, with making sure that we can try and get couples babies on their first IVF cycle, not their third.
Do you think, I'm sort of picturing in the future this sort of Minority Report, I don't know if everybody remembers that movie, but he had this giant screen, you could move
Matt
everything.
Damon?
Tom Cruise. Pretty similar though. You're thinking of Born Identity. It's pretty similar.
Yeah.
Action, 2000s,
I never saw
futuristic
Minority.
technology. The protagonist overcomes adversity to show us how humanity and technology can come together. And he's got this big screen and he moves things around. And I'm sort of picturing the REI of the future looking at multiple cases for different OBGYNs and maybe advanced practice providers, folks that are doing retrievals or that are seeing patients. Do you think it could be to the tune, as technology advances, to dozens of patients at a time, hundreds of cases that an REI is overseeing? Do you think it's too soon to be able to picture that?
I think that if you look at history and trying to implement technology in medicine, from laparoscopic surgery to AI diagnostics and decision support tools we have now, the cycle is the same, whereby, we start with kind of skepticism, the cautious exploration, then we have the forward thinkers and the early adopters who start to test and evaluate. Then we get the real world evidence, building, like we're doing with a study now. And then you eventually get implementation, whereby people have seen the data and the naysayers are suddenly like, great, this can improve outcomes. It's not an if. I think it's a when that automation of the IVF lab will become the standard of care. I mean, look at the Da Vinci robot. It's the same cycle.
Tell me about your experience with that.
Well, I train on the Da Vinci robot. I think it's such a great analogy because, when I was in training and you'd say to, just as you said, this futuristic world in an IVF lab where we have 100 data points, REIs are overseeing thousands of cycles, meeting the current demand. We have lots of data we can use to select patients. It will happen. And in the early 2000s, when it was, surgeons were saying, oh, we can do robotic surgery, most people said, come on, that's ridiculous. Who wants to do robotic surgery? And of course, there were the early adopters. People started to see that, especially urologists, that you could reduce blood loss, you could reduce hospital stay, you could improve patient experience. And those same naysayers and skeptics became, the proponents of robotic surgery, more so now, where they say, come to our hospital. They use robotic services to market their hospitals. We offer robotic surgery, and so I think that it's the same cycle where we will see this futuristic REI who's got a conceivable powered aura lab, who's got tons of data points and screens, who has 2,000, 4,000 cycles a year, and who has a collaborative kind of fertility care delivery team that has the OBGYN and nurse practitioners and REIs being able to meet this demand. I think, the sort of implementation and the sort of cycle of implementation of the Da Vinci robot is it's a great analogy. Now it's standard of care for urologists, gynecologists, because it's better precision, better outcomes. Cardiothoracic surgeons use the robotic surgery now. So
And all the surgeons are trained on Da Vinci now?
Not all surgeons are trained. Again, this is, if you think of how many surgeons around the world, but not, where when technology is implemented, the cost is high. And as you start to get, you prove the business case, you get competition in the market, economies of scale. We now have the Medtronic's Hugo, we have CMR's Versius. And so essentially what you have is, as the cost starts to come down, more and more hospitals can afford to buy a Da Vinci Da Vinci or other competitors of robot, and they're not as expensive. But it's pretty much standard of care for certain surgeries.
Do people go back? So if surgeons get good at using Da Vinci, do they say, I'm going to go back to the old way? Or once
I think the use case is always going to be there. So, for example, not the robotic surgery is not appropriate for all surgeries, but IVF, ICSI in a lab is quite standard, and that's why it's such a beauty to automate, standardize egg preparation, sperm preparation, ICSI, vitrification. It's pretty straightforward. It's almost easier than, implementing robotics into surgery.
I just don't see a world where the REI goes away. I think many of the people who are opposed to OBGYNs having more involvement in fertility care, they just can't visualize what they're going to be doing, and they think OBGYNs are running away with it. Or they think, oh, you OBGYNs are going to make all the money on these easy cases. We're going to be stuck handling a few of the complicated cases. But to me, it seems like there's so much for them to be able to do. There's still a major upside to the career. They're going to be overseeing many more people.
REIs will never go away. We don't want REIs to go away. We need to train more REIs because we're going to have demand that needs more REIs and a number of OBGYNs who are supporting this demand. And I think, again, we are approaching this all wrong because, of course, everybody's scared about change to their existing practices and making less money. But we need to go back to the ultimate problem. We need to scale IVF. Technology can do that. If we scale IVF and we have an additional 12 million cycles, we need more people to do this work, and nobody's going to make less money. What we need to do, though, is make it cheaper for patients so that more people can. You've seen the work of David Adamson. Cost goes down, utilization goes up. The demand is there. We know that. The data is out there. Not just infertility, the increasing need for family building in LGBTQ communities, recurrent miscarriage, over 3% of people, genetic diseases. The fear, and I think, innovation breeds fear initially, and I think that this fear in REIs is, as soon as we automate the IVF lab to increase demand, I think that will be a real domino effect, and everyone will see that there's nothing to worry about. There's enough work to go around, and nobody's going to make less money because, let's face it, I think that's what a lot of people are worried about.
Dr. Stephanie Kuku, you know the famous Mexican expression, Alejandro's oficina es su casa. Thank you for coming on the living room edition of Inside Reproductive Health. I've had a great time talking to you.
Thank you. So nice to be here.
Thanks.
Today's advertiser helped make the production and delivery of this episode possible for free to you. But the themes expressed by the guests do not necessarily reflect the views of Inside Reproductive Health, nor of the advertiser. The advertiser does not have editorial control over the content of this episode, and the guest's appearance is not an endorsement of the advertiser. Thank you for listening to Inside Reproductive Health.